So, good evening, everybody. I'm excited to be speaking to everybody about this topic, using micro-osteoperforations to grow your practice. Two topics I like, accelerated orthodontics and growing your practice. I myself am a private practice orthodontist, and so I will be speaking from that perspective. So welcome, everybody. Good evening. So just to clear things up, I'm not employed by any dental company. I own no stock or securities or interest in any dental company. There's no family member, immediate or extended, that is employed by any company that has any interest. I consulted for several companies over the years, and Propel Orthodontics has been one of them, Ormco, 3M, Oral Care, and Invisalign as well. I was just speaking to one of my friends yesterday who has helped me working in my office for a couple of years, and he said, gosh, David, you know, you're always right on the cutting edge of whatever is new and exciting. And I said, that's kind of what makes things interesting, you know. Our patients all want the same thing, and that's the greatest results in the shortest period of time, and they don't want discomfort. And so I'm always looking to find ways of how it is that I can offer the best treatment, the best results for my patients with the least amount of discomfort in the shortest period of time. So just a little bit about myself. I went to Arthur Dagoni School of Dentistry, or UOP, graduated in '96, graduated ortho program in '98, and I started 2 private practices in LA and Beverly Hills in 1999. I actually had a third one. I sold it in 2015. It was in Las Vegas. That was a fun place to go to, especially when I was single. Ormco Insider since 2007, 3M Unitech Research Panel, and I started using Accelerated Orthodontics in 2012, published a couple articles on it, and been speaking about it since. I've been a speaker consultant for Invisalign from 2002 to 2008. I've been an elite premier provider all the way back since 2002. Center for Excellence Incognito provider and premier provider for Damon and Insignia, and a key opinion leader and speaker for Propel. So a little bit about myself. I'm a third generation. My father was a dentist and my grandfather was a dentist, so I actually do have DDS stranded in my DNA, and I eat, breathe, think, dream, and live orthodontics on a daily basis. So this is something I'm real passionate about, and hopefully you guys will get to see why it's so exciting. So a little overview about accelerated orthodontics. I'm going to talk about the history. I'm going to talk about what are micro-osteoperforations. I'll talk about the science behind micro-osteoperforations. We'll look at some animal and human studies. We'll look at some advantages and some fees, and how to present fees and how to discuss that to patients and to your team, and also how to market micro-osteoperforations. And so in this presentation, because it is a certified presentation that you're getting CE units, I will be talking about micro-osteoperforations. I really won't be talking about the company so much, but there will be a little bit on it. So a little history of micro-osteoperforations and the drivers. So you can see on the top right-hand side, that was the first version, and then there's the middle one, which is the sterilizable handle with a reusable handle with a sterilizable handle grip with the tip that can be removed, and it is a one-time use and is disposable. And then the third picture down at the bottom is actually now moving into an automated unit where it actually has a mechanical device where you click a button and it'll do the turning for you, so it's not manual. So the company started in 2011. In 2012 was when the clinical trials happened, and over 300 patients where treatments were performed. 2013, 6,000 devices were sold into private practice, integrated in over 25 universities. In 2014, there was over 200,000 treatments performed, and also the drivers were given the best of class winner at the Pride Institute. And so in 2015, there was over 350,000 treatments performed and featured in 18 different industry journals. So we're definitely getting a lot of traction on the device and on the procedure. And I think that what's really cool about this is that we're using science. This is not a gimmick. This is not something that just came along out of nowhere. We're actually using our own body's biology to accelerate the treatment. So, we look at this case at the bottom, and I'm sure a lot of us would say, oh, well, those, second molars aren't fully aligned with the first, and I would agree with that. But this is just a quick example just to show you, with using some passive self-ligation with temper anchorage devices and Propel, how quickly we could close this space, and we closed this space in 8 months. So a very difficult, situation. And I think what we're going to find here is that dimples or micro-osteoperforations are all doing the same thing, and that's stimulating a cytokine release. It's stimulating a response from the body, basically an inflammatory response, and that inflammatory response is causing the bone and the body's biology, or the biology of tooth movement, to accelerate overall. And so overall orthodontic tooth movement we're moving faster, and the treatment time is reduced. Currently, we can use this in conjunction with any orthodontic modality: Invisalign, Incognito, Insignia, SureSmile, any kind of self-ligating, passive, active, fixed or removable, even functional appliances, surgical cases, impacted teeth, uprighting molars. If you're moving teeth, you can use micro-osteoperforations to create that inflammation and cause the body's bone to start to oppose faster and create change in a shorter period of time. So we're not going to be using any more force, not trying to increase the force level. We're not going to tie the chain tighter or use a bigger spring. We're going to use the same mechanics that we normally do. And so when I usually find myself in this situation where I'm being presented a new technology, I always ask myself these questions. Should I be the first to try it? Is there real science backing this up? And I assure you there is, and we'll review that. Do I want to be an early adopter? If you look at that bottom screen there with all the sheep kind of climbing up the hill, I'm usually not the first guy, but I'm usually in that first pack right behind him. To me, that's just exciting. Sounds cool. Some people just say, well, let's wait and see. When I was in school, they used to tell me all the time, they would say, don't be the first one to do it, but don't be the last one to do it. And so in the 17, going on almost 18 years now in practice, I have been kind of an early adopter with various things like Invisalign or self-ligating brackets, or now with Propel and Accelerated Orthodontics. And so to me, that's interesting, but for some people, they would rather be in the latter part, the second group, or the majority. And so what we find is that the technology is introduced, but how long does it take for everybody to get on board? And when it came to Invisalign, it took many years. I mean, gosh, I mean, it really didn't get traction for almost 5 or 6 years. Well, I think Propel, as you can see those numbers, from one year after the next, is getting a lot of traction, and I think that it'll probably be adopted a lot quicker than let's say, Invisalign. And so I think it's quite an interesting modality to now offer your patients, especially when patients are always asking the same thing, and that's when they come into the office, they say the same thing. And I think we all have the same patients saying the same thing, which is, when are my braces coming off? I love my patients. My patients love me, and whenever I see them, I say hi. Some of them I might give a hug. I'm very friendly. I'm personal with them, but they all ask me the same thing. Doc, I love you. When is my braces coming off? When is this treatment going to be done? And now I actually have an answer. In the past, it was always well, let's give another 6 months. Let's give another 4 months. And I'm sure you guys all know what I'm talking about. So this next slide, this research has been out for, gosh, it dates back all the way till 1988. So it's almost 19 years now that we've had this information, and really what we're looking at is application of anti-inflammatory medications decreases tooth movement significantly. And so all of these studies in 88, and 06, and 2000, all of these people saw that if we introduced anti-inflammatory medications, Advil, Aleve, Motrin, Excedrin, naproxen, any of these anti-inflammatory, non-steroidal anti-inflammatory drugs, it decreased tooth movement significantly. And the animal studies, if they knocked out the cytokines, it significantly decreases the rate of tooth movement. So it's in animals, it's in human beings. No matter where we looked, we kept finding the same thing. You block the cytokines and you decrease the rate of tooth movement, because the cytokines are related to the biology of tooth movement. And so The biology of tooth movement, we all are familiar. There's a tension side, there's a pressure side. On the pressure side, there is usually some kind of decrease in cell proliferation, and there's going to be some resorption. And on the tension side, there's going to be cell proliferation, and there's going to be apposition. We're going to be laying down new bones. We're all very familiar with that process, and so with a force applied to a bracket, through a wire, or Invisalign, or however we want to move teeth, this is typically what it is that we're going to be seeing. And so what we start to see is we see resorption, or frontal resorption, on the pressure side. And we do see a little bit of some vascular constriction. And obviously there was lots of data to show that when we used very high forces, we had a high level of vascular constriction. And so I think it's been pretty well played out in science and in all of our studies that lower pressures, more biologic forces, tend to decrease the amount of vascular constriction and therefore cause tooth movement to happen a little bit more reliably. And so lower forces have become a little bit more popular. We see less side effects. And so when we talk about accelerated orthodontics, everybody always says, oh, you're moving the teeth faster. And I would say yes, but I would also say no. And the reason I say no is because we're actually using the same level of force that we normally would, but we're seeing a biologic response much different than we have in the past, almost at the rate of 40 or sometimes even 50% faster. And so that's pretty exciting clinically, and so I'm going to show you what I'm talking about. So these are just some diagrams kind of showing how the tooth is moving, and sometimes when we get some big tip, we might get a little bit more vascular obstruction or hyalinization in that area, and so that's kind of where we're seeing the little red areas. And ultimately, the body responds best when we use very light forces and we allow the body to make the change over time, and we try to stay away from necrosis. We try to stay away from that hyalinization process. And so micro-osteoperforations works with the patient's own biology by stimulating a cytokine response. Basically, we're creating little micro-fractures in the perforation process, and that fracturing of the bone then stimulates the cytokine response, or stimulates an inflammatory response, and then the body starts to respond a lot faster because now we have an increased level of cytokines in the area. So in orthodontics, we know that the rate that bone remodels determines the speed of tooth movement and a patient's treatment time. So the NYU study, which was sort of the pinnacle study, showed that incorporating micro-osteoperforations into patient's orthodontic treatment, the tooth movement could be increased 2.3-fold, or may lead to 40 to 50% reduction in treatment time. Now, the study only looked at a 30-day time frame, so I will show you that study, and we'll talk to you a little bit about what I've seen clinically in my cases for overall treatment time versus that study. So bone remodeling, we're all fairly familiar with these pictures. Hopefully some of these cells look somewhat familiar, but there's our blood vessels and our monocytes and our pre-osteoclasts and our osteoclasts and macrophages and osteoblasts. And so of course we know the resorption occurs on the pressure side, and then reversion, and then formation, and then mineralization. And so this process of bone remodeling, what we're seeing is basically happening faster by an increased cytokine response. So how do cytokines affect orthodontic tooth movement? Well, decrease in cytokine response equals a decrease in tooth movement. So how do we increase the cytokine response so that we can increase the tooth movement? So what some of the studies found in 8806, it was Chow, Arias, Kirakonidase, and Bartzella, found that the application of anti-inflammatory medications decreases tooth movement significantly. In the animal studies, if they knocked out the cytokines, it significantly decreased the rate of tooth movement. If cytokines play an important role in activating bone remodeling machinery, then we should be looking at how we can control cytokines, and that was basically in 03 and in 05. Bone remodeling is the basis for orthodontic tooth movement. That was Deguchi and Krishnan and Davidovich in 08 and 05. And then cytokines play an important role in orthodontic tooth movement in 2010. And so cytokines in all these studies are the kind of the game changer, or the aspect that we're looking to change. So when I was in school, I was actually looking at how I could do some research, maybe a drug, that we could have a patient take that could cause the tooth movement to happen faster. And unfortunately, we couldn't design the drug so that it only went to the alveolar bone. It ended up affecting all the bone. And so now we actually do have a technique that we can affect locally the alveolar bone with no negative side effects of the rest of the mouth or the rest of the body. No liver toxicity, for example, with most drugs, or no negative side effects, which most procedures and drugs typically have. And we're going to actually change the way that the body responds. So we're going to create bone injury. We're actually going to introduce inflammation to the process. We're going to see an increase in the cytokine production. We're going to see an increase in the rate of bone remodeling. And of course, another thing is that we're getting a decrease in bone density because of the inflammatory response and, of course, the fact that we're just perforating the bone. So different modalities in accelerated orthodontics. Micro-osteoperforations is not the only way to move teeth faster. So there are some patient-controlled devices out there. The one on the left is the first version of the BioLux, and there actually is now a new version of BioLux that hasn't been released yet, but it is an intraoral device. This is an extraoral device, and you can see it's almost kind of like a headgear. And so the patient would have to self-administer and do it 20 minutes a day, just the same with Accelerated, which is the picture over to the right. And they just use two different mechanisms. The BioLux machine is a light-activated bone regeneration. The light activates the soft tissue, which then stimulates the bone. They're seeing somewhere in the range of about 30% reduction in treatment time. With the vibration, with Accelerated, it is a rechargeable device. It requires patients to administer it themselves for 20 minutes a day. It does rely heavily on compliance. If the patient doesn't do it regularly, then it doesn't work as effectively. And the cost of the patient is usually about $1,000. So the device is a little bit on the pricey side, but it is a nice option because if the patient is compliant, it can create some change in the rate of about 40 to 50%. There are some other techniques a little bit more invasive. We have corticotomy procedures, also known as Wilcodonics. We have piezo surgeries, and then of course now we have the micro-osteoperforations. So corticotomies are probably the most invasive, the most time intensive, requires the patient a fair amount of recovery time, usually a week or two, depending on the individual. There is a fairly high cost to the patient. Of course, I have heard Wilcodonics, some patients, the next day they go into work, but of course those are what I call outliers. Requires extensive training for the clinician, and typically, orthodontists are not doing corticotomies. Typically, they're working with an oral surgeon or a periodontist to do it, so it is a procedure that has to be sent out. There is some morbidity to it, especially if a patient had some compromised health issues. But for the most part, we're not finding a ton of side effects, although the literature does show that anytime that you lay a flap, a full thickness flap, you're going to get some levels of recession. And so that's what my concern is, although I've heard many people tell me no recession at all on very healthy patients. So there is some very promising data out there on corticotomies or Wilcodonics. Piezo surgery is a little bit less invasive, but still requires a flap. There's a tunnel procedure, or requires the patient also recovery time. There is a high cost, and typically that's also not going to be done by the orthodontist. It's going to be done by a periodontist or an oral surgeon. So with micro-osteoperforations, they are micro-invasive. It can be done in the office at the chair. I usually do my perforations right next to the patient that we're changing a wire on, or replacing a TAD, or we're giving him a new aligner, or we're activating a spring. And so it's not something in our office that we find that we have to pull them into another room and that we want to hide it and that we don't want people to see. The patients are numb and they're handled properly. In fact, I think it raises more questions if people say, oh, what are you guys doing over there? I want to get my braces off faster. So it is something that we do a lot in the office. I don't do it on every single patient. I know that there are some people out there that it's all or nothing, and I think that there are very specific applications, and I'll talk to you about what those are. And for me nowadays, it's if the patient wants to get done faster, that's the right application. So a lot of times the reason that I don't actually do it on all the patients is not everybody wants to have their treatment done faster. Not everybody wants to pay extra. Not everybody wants to go through an additional process. Some people have some kind of fear. Of course, through education and explaining it to them, a lot of times what I find is that I'll plant the seed, at one appointment, and then 2 or 3 appointments down the road, they're coming back to me with, I really want that. Let's revisit that concept, and how easy is it? And I saw someone over there getting it, and I want to get these things done faster, and so they become real motivated. So the 3 different devices are here. There's the single-use handle with the driver, and it has a little light that illuminates, tells you the exact depth that the driver is perforated into the tissue. And then the reusable handles have a little bit more of a refined sleeve with a better screw and disposable tips, and a reusable handle that can be sterilized. And then the third version is now an automatic device where it is automated, and you can push a button and it moves the burr very, very slowly. So it's on kind of like a slow speed, but it's much, much slower. It's designed for placing implants. Micro-osteoperforation should only be created with a device specifically designed for micro-osteoperforation treatment. I've had several people come to me and ask me, why can't I just use a round burr and just perforate like that? Or why can't I just use my TADs? And TADs are designed for placement. They're not designed for placing them and then removing them and then placing them and removing them. There have been some incidents of the head actually breaking off, although I know people doing all kinds of stuff. But I've also had some people tell me about that high speed with the round burr, and of course that creates necrosis. And that would have the opposite effect of what we're trying to create here. And not only that, I've heard stories of tissue getting wrapped around the high speed. And so for whatever money that we're saving by trying to use those other devices, I don't think that medical legally it's covering you. So you're doing a procedure that is fairly new. It is approved, but now you're using a device that isn't approved. And so if there was some complication, which I highly doubt, then it would come back to you that way. So I think micro-osteoperforation drivers create micro-osteoperforations to stimulate a natural cellular response, harnessing the patient's own biology to accelerate tooth movement, and I highly recommend using the devices that are on the screen that are being provided to you by Propel. The benefits of micro-osteoperforation. So patient benefits: minimally invasive, performed chairside in minutes, used with whatever type of orthodontic treatment you're using, aligners, braces, releases difficult movements. So let's say you've got an aligner case where you're having some troubles. You could just do one session of perforations, and that could get you out of the situation. If it didn't, maybe 10 weeks or 12 weeks later, you would do another one. Accelerates treatment, increases treatment predictability. I'm going to expand a little bit on this. Increases treatment predictability to the point where it actually now is changing the way that I'm diagnosing and treatment planning my cases, because now if I can do more and I can be more predictable and more reliable, I'm treatment planning things that I didn't treatment plan in the past. So no patient recovery time needed. I usually tell patients, and I have found it's literally 24 hours or less. The holes seal up really nicely, and the patient doesn't have pain after that. Doctor controlled, there's no patient compliance, saves time. Less office visits means less time off work or school. So patients really like that. And so do doctors. Practice benefits. Cutting edge technology, increased treatment acceptance. Patients want shorter treatment all the way around. It does attract new patients who are interested in looking for faster treatment times. Practices embracing latest technology that is for a lot of patients. Incorporate a premium treatment option fee, which we do. Reduce patient burnout and increase predictability of orthodontic mechanics. And so by incorporating a premium, I incorporate a higher profit margin. I know this is a clinical presentation, but we all run businesses, and there's nothing wrong with creating a larger profit and being able to take something home to our families. So animal studies. Let's look at how real the science is here. So there's an experimental rat jaw, and so what was done was a control, so a rat jaw with no tooth movement, orthodontic tooth movement, so rat jaw with just traditional braces with springs to open up a space, and then orthodontic tooth movement with perforations. And you can see the significant increase in the amount of space that was created in the same time frame with the same force levels, for the control versus just ortho versus perforations. And this is typically what we're seeing, not just anecdotally in what it is that we could measure as far as the space, but we're also seeing it scientifically. So when we look at the expressions of cytokines in these three different groups on this animal study, what we're looking at here with these graphs, the white bars are ortho, just the rat jaw with just orthodontic movement, and then the yellow is orthodontic movement with the perforations. And you can see that with every marker, every type of cytokine that we're looking at, you can see that there's a larger amount of expression by the yellow bars being higher than the white in basically every example here. And so it proves out that doing orthodontic movement with perforations, you're going to see a greater gene expression, a greater level of cytokines in the area, and a reduced treatment time. And what happens with the bone? So when we start to look cellularly, we look at the control, and you can see that there is some activity, but not quite as active as the ortho with perforations. And you can see an increased amount of cellular activity in just the orthodontic model. But ortho and perforations is a dramatic increase in the cellular activity, and that's because we've created inflammation or an increased amount of cytokine response. These rats weren't given any NSAID, so we saw a great response, and you can see that cellularly. When we look at the electron microscopy, when we look at the cellular level, you can see the control versus the orthodontic group versus the orthodontic with perforation. So the cellular activity that's going on there is just a lot more active. And so when we look at histological slides of the same controls, the rat jaw without any orthodontic movement, rat jaw with ortho, and ortho with perforations, you can see the cellular activity there in this slide is dramatically greater than in just the ortho or in the control. And so we can see all the various little cells. And so when we looked at the canine retraction, we looked at control versus osteoperforations, and again, it was the same result that we found, is that the osteoperforations had a greater level than the control. So you can see dramatically greater, and it was in all areas, in the lower third, in the middle third, or in the upper third. So osteoperforations in relation to control, there's a significant difference. So human studies. The human studies at NYU utilized micro-osteoperforations device to create those perforations. They saw that it reduced treatment time for the length of time that they saw by 62%. Of course, I never would quote anything quite that high clinically in my practice because it's a little bit unrealistic, so I talk about 40%. Now, the clinical trial demonstrates 2.3-fold increase in velocity of tooth movement when they looked at a split mouth study, one side canine retraction versus another. So I think that the study is very significant. We did see bodily movement and no tipping, and the patients reported little to no post-treatment discomfort. And so on the right side is just the ortho only, and you can see we're using a little power arm with a little NiTi spring, and they made sure that they measured the force that was created from the TAD to the power arm, and they did that on both sides so that the force levels were the same. And after 30 days or so, 28 days, you can see that the left side, there was more retraction, more space opened up than the right side. And so definitely the ortho with the micro-osteoperforations created a larger amount of tooth movement in the same time frame. And so those were the cytokine levels. And so in the first day, of course, we had the greatest response. And so the osteoperforation we can see is dramatically in all four of these graphs. The osteoperforation versus the control is higher. And we can also see that there's a little bit of a decrease over time. And so when we first started, that decrease indicated to us that maybe we needed to do perforations maybe every 6 weeks, maybe even every 4 weeks, maybe even 8 weeks. And so what we started doing is doing a lot of these perforations too soon. And the studies that we're seeing now is that we don't have to do it every 30 days. We can actually do it every 3 months and still have the same effect. Some people do it on a 10-week cycle instead of a 12-week cycle, but it's about between 10 and 12 weeks. Is typically what I'm doing. So orthodontists and patients alike are interested in techniques that can accelerate tooth movement, and this article in April of 2014 showed that basically everybody is interested in getting treatment time reduced. Some other articles. This article was published by John Poband, Storini, and actually Nick Azizis in Brazil. basically introducing, Propel or micro-osteoperforations to the alveolar bone and how that changes the cytokine response and reduces treatment time. There's another article here. This was done by Miraglia. This is in summer of 2013. Another article here by Nick Azizi in August of 2013 in Orthotown. And then the Al-Kahani AJO article was in November 2013. This was sort of the landmark article that really basically launched the concept of doing micro-osteoperforations clinically. Innovative techniques, Miraglia published that article in November 2013 using Propel and clear aligner therapy and showing that you could actually have the patients advance in their aligners with the Propel, and I think he was talking about a 7-day scenario, and then Shipley's article even talked about sometimes 5 days, sometimes even 3 days. And so this is Karen Gwynn's article, December 2013, enabling faster, more predictable results. I'll show you a couple of her cases, some things that turned out really, really incredible with some intrusion. I'll show you that at the end. And then this is another article by Shipley. This is the one I was talking about where he actually talks about introducing 3 days or even 5-day cycles in between aligners with it being effective, with micro-osteoperforations. It was quite an interesting article. If you haven't read it, I definitely recommend reading it. It'll change your mindset on how fast you could potentially get through aligner treatment. And that came out in April of 2014. And then my article that was written in April or May of 2014 was in Orthodontic Products, and it basically talked about accelerating treatment, and I did do a combo of Propel and Accelerant in that article, talking about how I use it clinically. And then in this last article by Nick Azizi, it was he titled it The Fourth Order. It's a great article. It talks a lot about these things that we would consider to be unpredictable, and now they are predictable because we have control over how the body's biology is responding to the treatment. So in the past, we've spent years and years on figuring out how our biomechanics can become more effective. So there's incredible thought leaders in our history. For example, Burstone is one of them. They came up with really cool mechanics that were very, very efficient, but were slightly bulky and were slightly uncomfortable for the patient and made it difficult for practitioners to successfully duplicate. And so here, what we've done is we're now saying this is independent of the biomechanics that you're using, the system, whether you're using a twin bracket, a self-ligating, passive, active, whatever it is that you're choosing to use, you're actually now changing the way the body's biology responds. And so if you then start to combine, and I'll show you some of these cases where you're combining the new technology like passive self-ligation, TADs, you can really do some things that are quite incredible. So this is a micro-osteoperforation technique guide. It's created by Propel. Basically, it shows the sequence. So we evaluate the areas, we rinse with Paradex, we anesthetize. Typically, we're going to use topical, a very strong topical, and then we're going to place the micro-perforations and set the depth based on certain areas of the mouth. And I'll talk to you specifically about how that works. And then, of course, at the end, we'll give patients instructions on, not to use any NSAIDs. That would sort of counteract whatever it is that we're doing with the micro-osteoperforations. And so we strongly emphasize that after this procedure, the only thing they can take is Tylenol. They absolutely cannot take anything else. And we must say it probably 5 times throughout the procedure. So 3 easy steps in minutes. And so this is evaluate treatment, palpate the tissue, evaluate the x-ray. And you can see here when we're looking at the anatomy, if we're going to be typically from the marginal gingiva or the papilla, we're maybe going down 3-4 millimeters, maybe into attached tissue. Maybe one perforation might be into the mucosal tissue, but we're very, very far away from the nerve or from any kind of vascularity there. So we're typically going to be up in this area when we're doing the perforations. And it's really not about the depth of the perforation. It's really about just breaking the cortical plate. So when we understand that, then we start to recognize that we're really not trying to create big, deep holes. We're just trying to create microfracture into the cortical plate, and that's really what causes the biggest response. So we clean the mouth with the chlorhexidine. Usually we have the patient rinse 2 times for 1 minute each. We anesthetize the patient and perforate. So the treatment area can be anesthetized by using a regular topical, which we usually start with. Some kind of a flavor makes it fun for the patients, or a local infiltrative anesthetic, or a compounded topical. We will typically use a regular topical, benzocaine, and then we'll go with a compounded topical. And the compounded topical, there's a little formula on the bottom right-hand part of the screen where it's a compounded topical, so you have to order it from a compounding pharmacy. And this is basically the prescription. If you need help, the reps can also help recommend pharmacies. There is one topical that people seem to like. They call it the baddest topical in the West or something like that. And ultimately, it's got this prilocaine and the phenylephrine, and it is basically much more profound. It's almost like giving a patient a local. And so we've found that on many of the patients, we can skip giving them a local, and we just use the regular topical and the compounded. Some a little bit more sensitive patients, we have had to use a local. Micro-osteoperforation depths are determined by soft tissue thickness and penetrating the bone at 2 millimeters. So if someone has more soft tissue thickness, then you're going to want to go in a little bit deeper. And if someone has thinner tissue, you're not going to want to or need to go in as deep. And so let's look at how this technique works. So a single use, you would typically set your depth at either 3, 5, or 7. That's with this older device. With the reusable device, you're basically setting it based on how far the sleeve goes down into the little handle here, and there's like little millimeter lines, kind of similar to like a perioprobe, and so you know your depth based on the millimeter lines, and each one is 3 millimeters. Remove tip of choice from the sterilized packaging. Insert the tip right into the handle, and then you're basically going to hold the device at 90 degrees to the gingiva, and then you're going to rotate clockwise, applying gentle pressure. And based on where you are in the mouth, it's going to be based on the depth and also the thickness of the tissue. And then we're going to be rotating counterclockwise to remove, and the handle is designed to be sterilized and reused. The tips are disposable on a one-time use. So treatment considerations. Most patients require 1 to 2 treatments. Complex cases may require 3. You know, what we're doing in the beginning, the first part of most treatments is leveling and aligning and dealing with big movements, and as we get closer towards the end of treatment, we're dealing with very small movements, and in that finishing stages, typically I'm not doing the 3rd or the 4th Propel or micro-osteoperforations, excuse me. I'm usually doing 1 or 2. So if I have to do 3, I'll do it. 2 to 3 micro-osteoperforations are recommended mesial and distal, and so some of the research now is actually starting to show that you could actually skip over one surface. So let's say you did 2 to 3 perforations on the mesial of one tooth. You wouldn't necessarily have to do the perforations on the distal of that tooth, because the osteoclastic response we're finding is about 6 to 10 millimeters around the treatment site. So for acceleration, we can perforate around rate-limiting movements. Like for example, let's say I want maximum anchorage. I'll do no perforations around the posterior molars. Let's say I want it the other way around. Let's say I want maximum anchorage in the anterior and I only want to move the posterior. Well, then I'll just perforate in the posterior. So depth selection is typically going to be, in the anterior is going to be about 3 millimeters, and the posterior is going to be about 5 to 7 millimeters, and in the palate is usually going to be about 7 millimeters just because of the thickness of the tissue. Osteoclastic effect peaks in 24 hours and remains elevated for 10 to 12 weeks. The treatment may be repeated 10 to 12 weeks or as deemed necessary. I have not found that when I was doing a 6-week or 8-week that I was getting any better response. The same thing when I was doing 3 perforations on the mesial and the distal of the tooth, I really wasn't finding that I was getting any greater of a response if I just did 2 mesial and distal, or now if I just do 3 on one side and I don't do the other side. So there are some things with this technique that are kind of evolving over time. And this is a nice picture that shows us how we would do those perforations. So these are either 3 vertically, or maybe 3 in a triangular shape, or maybe just 1 in certain areas, or maybe just 2 in certain areas. Now typically I'm not usually doing them right here in the middle of the centrals because of the frenum attachment. And so I typically will not be perforating into any kind of frenum attachment. So if the frenum is real low in here, I'm just going to stay away from it. And typically in the middle there, I'm going to stay away, also because the bone tends to be a little bit thin, and also the patients tend to be a little bit more sensitive in those areas as well. And so if I know that if I can do my perforations here and here, and it's going to have an effect here, then maybe I don't have to do perforations into frenum attachments and not create any negative side effects with that. Where possible, perform 2 to 3 micro-osteoperforations depending on the proximity of the anatomical structures. Perforations can be made buccal or lingual in linear or triangular patterns. How deep to perforate? So this is a nice diagram showing in the upper anterior and lower, maybe 3 millimeters. Of course, if you had a certain patient population that had a higher thickness of tissue in those areas, then maybe you might be perforating at 4 millimeters. In the posterior, it says 5. Sometimes there are some scenarios where you might want to go 7. But again, it's really not so much the depth, it's really just about understanding the concept that you need to create some microfracture on the cortical plate, and that microfracture will then cause that cytokine response, cause the inflammation, and cause the treatment response to happen faster. So this is an example. On the screen you can see some pictures post-perforation. And so here in this picture there were 2 dimples, and in this picture I think there were 3. So you can also see in this picture placing perforations on the lingual. Typically when we have impacted cuspids, we're going to be perforating on the lingual. So buccal access is most often the simplest approach, but it really always just depends on the desired movement and the patient's anatomy. So post-perforations, you can see this is probably like an hour, maybe 30 minutes after the perforation. So you can see that basically by the time the patient leaves, that very small hole will typically close up, and they won't be bleeding when they leave the office. And that's something that's another practice management or customer service concept. You don't really want patients walking out if they're still oozing a little bit of blood, especially if they're wearing aligners. Then the blood gets in the aligners and it doesn't look good. And if you take a look at that picture, the small little circle around there is actually the sheath that gets pushed back on the driver that tells you your depth. And they do make disposable tips that don't have the sheath if you just want to just see the screw, and you could measure it with your eye on your own. But that is what ends up happening, and usually the next day all this is all healed up. Post-treatment instructions. So the patient may experience some tenderness around treatment site for maybe 24 to 48 hours. Most people have told me it's never been more than 24 hours. This sensitivity is similar to that of an orthodontic adjustment. Patients should not take any non-steroidal anti-inflammatory drugs, only Tylenol. Micro-osteoperforations are going to be repeated in 10 to 12 weeks, so you can set up another appointment for that. And post-treatment instructions are very similar for local or topical anesthetic. They have to be a little careful not to hurt themselves, because when the anesthetic wears off, we don't want them to have any pain there. The benefits of using micro-osteoperforations with aligners. Wow, what a cool concept. Now we're going to increase the tooth movement, increase the rate of tooth movement. We're going to decrease the overall treatment time, and we're going to do it with Invisalign, which is typically considered to be unpredictable. Now we're starting to introduce something that will make your Invisalign dramatically predictable. So micro-osteoperforations with aligners is probably one of the coolest things ever, because now it makes your aligners treatment work really, really reliably. So increased appointment intervals. Now instead of seeing the patients maybe after 2 aligners or 3 or 4, now we give them 6 or 8 or 10. And so we'll see them back 6 weeks, 8 weeks, or 10 weeks, all depending on their compliance level and where they are in treatment and who they are as an individual and what their schedule and things are like. But we're going to avoid refinements. And if we do have to do refinements, they're going to be short refinements, 5 or 10 aligner refinements. Avoid mid-course corrections. Expedite treatment results, reduce aligner lag, improve the tracking of the teeth, keep cases on track, increase treatment predictability, facilitate challenging aligner movements, and reduce chair time and increase profitability. So man, all that sounds awesome. I don't know why I just wouldn't do it on every Invisalign case. And like I was saying before, I don't do it on every person, and it's usually because the patient doesn't always want that. And so I'll ask them. And of course, what's interesting is now I introduce it at the exam, and they might say, no, that sounds invasive, I don't know, da-da. And then 2 or 3 appointments into it, they're like, doc, what was that thing that you were talking about that can reduce treatment time, that I just have to make little holes into the bone, or little dimples, or what were you talking about? And then it just triggers the conversation, and I would say that I probably have a really high acceptance rate after they've started treatment, in fact higher than before. And I think that that's just because people are slightly reluctant at the beginning, but then once they get into treatment, they're really motivated to get done. So this is just another concept of acceleration. We can do acceleration either proactively or reactively. And what do I mean by that? When I say proactive acceleration, I'm going to be talking about doing it right at the beginning of treatment. So perforate the appropriate area and provide patient with aligners, and you can see the chart below. You're going to schedule follow-up visits accordingly. So instruct the patient to call the office if aligners do not fit, the same as the initial visit, and we're going to record dates on the aligner bags and instruct the patient when to change out aligners. So we can do 5-day intervals, we can do 7-day intervals, we can do 9-day intervals. Typically, most of the time I'm doing 7-day intervals. I found that 1 week for each aligner tends to be very effective. Shipley was talking about even 3-day aligner intervals. But if you did do a 7-day, you can do 7 aligners, 7 weeks later, and so you're really going to be reducing your overall treatment by not having to see the patient. So now you've reduced the number of visits to the office. You've made it much more convenient for the patient. You've now increased your predictability, tenfold, and the patients love it, and you're now able to do things that you probably would never think possible with Invisalign. Now, reactive acceleration. This is a patient that is already in treatment. We've had some problems with the way things are going, and so now what we're going to do is we're going to react to that problem. So the patient's saying, why isn't this working? And we've done a refinement, and it still isn't quite working, and so now what we're going to do is start triggering the body's biology to respond to our mechanics. And so we're going to return the patient to the best fitting aligner. We're going to perforate mesial and distal to the non-tracking tooth or teeth, and we're going to deliver 3 aligners and schedule a follow-up visit in 3 to 4 weeks. And typically, what I'm finding is that if you do have a situation with Invisalign where it's not quite tracking, or you're having problems with the tooth responding, and you do those perforations, and you decrease the density, you increase the inflammation, you increase the cytokine response, the aligners will now start to do what it is that they haven't been doing, and it's pretty impressive. So what are some benefits with brackets? Well, we're going to expedite treatment results. We're going to keep cases on track. We're going to increase predictability. We're going to facilitate very challenging movements. We're going to reduce chair time. We're going to increase profitability. We're going to promote accelerated orthodontics to the patients and the community as a whole. And the treatment plan, we can now begin to treatment plan much more difficult movements with more reliability. And that's because now we have an effect on the body's biology. And so to me, you can obviously already hear in my presentation that I'm pretty excited about this. And when I show you the cases, I think you'll be pretty impressed and excited as well. So proactive acceleration, a little bit more about that. Maintain the same biomechanics. You're going to decrease the time between appointment intervals. So for braces, you're going to have to see the patients more regularly. In other words, typically in my mechanics without acceleration, I might see a patient every 6 weeks, maybe every 8 weeks, and there are some appointments I might even go 10 weeks in between appointments. Now, if you do that with acceleration, then you burn out your acceleration time because, again, your perforations only have an effect for 10 to 12 weeks. So if you give someone a wire and you say, I'll see you back in 10 to 12 weeks, then you just missed all of your opportunity to accelerate the patient. So you will have to see the patient a little bit more frequently. So instead of seeing them every 8 weeks or 10 weeks or 6 weeks, I'm bringing them down every 3 to 4 weeks. So many cases are going to be delayed by these difficult movements, and so I think that MOPs are going to be required. And when we use these MOPs, we're going to do like what we talked about, perforate based on the depth, based on what we're talking about. And what we're going to do is we're going to accelerate mesial and distal to the teeth that we want the movements to occur on. Now, sometimes, like in braces, I don't want all the teeth to move, so I'll use the MOPs to control where I want the teeth to move or not. In Invisalign, it's the same thing, and so I have the ability to control it or localize it, whereas with corticotomies or with removable devices, Accelerated or Biolux, those things are not localized. Those are very generalized. So with braces, you'll have to see the patients a little bit sooner, and part of the reason why is because typically if I put a wire in, I would usually have to wait 8 weeks to see that treatment result. If I'm doing perforations and I put that same wire in, I'll see that patient back in 3 or 4 weeks, and I'll see the same exact treatment result that I would have seen at 8 weeks. And I'm basically forced to have to then change them into the next wire so that I can then progress the treatment. So the body is now responding a lot faster. I'm not using any greater level of force, but because the treatment result is now happening faster, I'm able to then go to the next wire and advance the treatment and see the patient in shorter intervals. With aligners, the opposite. I don't have to see them in shorter intervals. Now I can give them more aligners. They can change them out on a weekly basis, and it actually decreases the number of visits to the office. Now what we're finding is even though I'm seeing the patients on a 3 to 4 week cycle, their overall number of visits to the office are reduced, and their overall treatment time is still reduced. But it does change how I schedule things a little bit. So acceleration patients have to be seen a little bit sooner with braces. With Invisalign, you can spread them out and see them even longer. Micro-osteoperforations facilitate successful completion of all kinds of malocclusions. So there's just a short list. I think it covers most things, but you can correct pretty much almost anything with orthodontics with the combination of MOPs. So picture-perfect selfies delivered ahead of schedule, and that's kind of the thing that the millennials want. That's what everybody wants now. And I think that that's what the patients are asking for, and I think that if you're not on the cutting edge to be able to offer that, then I think the patients will look and seek someone who is offering that in their area. So to me, this is kind of the fun stuff because it starts to show you what it is that I've done, and it's not just talking about what could be done. And so these are some samples. These are some of the first patients that I started using micro-osteoperforations with. This patient had a very large diastema on the left, and we closed it like in, I think it was like 4 months. Maybe a little bit longer, but I mean it was really, really fast. This patient here, we found something interesting. We found that his head actually got smaller as I started closing the spaces. I'm just kidding. His head didn't actually get smaller. It just happened when I laid it out through Dolphin. That's the way that it laid it out. So I thought that it was so funny that I would keep it that way and not size adjust it because I think it's kind of funny. But basically, the first picture, time point 1 to time point 2, was probably almost a year, maybe a little bit more, very, very little changes. And then once we did the perforation, we were really able to get things going. Some patients, the biomechanics that I would be using would be very effective, and this patient's spaces would close very easily. But in some patients, the same biomechanics gives me a different treatment result. And if that treatment result isn't what I want, the only person that's responsible for that is me. And the patient looks at me and goes, "What's going on? What are you doing? When are my braces coming off? Why aren't my spaces closing? What, da, 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 da." And I have to have answers to these things. And in the past, I would just say, "Don't worry, I'm taking care of it. These things work. It just takes time. The body will respond." And then sometimes, like in this case, I end up in the case way too long, and then you start to really think, well, gosh, why do I need to be spending that much time for patients? I need another solution, and more force is definitely not the solution, but triggering the body's biology is. So this is a reactive treatment. We did it after we were in trouble, and so this is the initial. It was March of 2010. And so it just looks like a fairly standard, spacing case. Bimax protrusive, class 1, no cross bites. Doesn't seem too difficult. And I think with traditional mechanics, it probably wouldn't be difficult. But of course, he didn't want to do traditional mechanics. He wanted to do incognito. And so we can see that the progress after a year is very little progress. Spaces are not closing, and it's not because the mechanics are not allowing me to close it. We can see that in the 2-to-2 area, there is no kinks in the wire, and we're just retying chain. And even in the 2-to-2 area, I can't seem to close the space. So it has nothing to do with the wire not sliding properly. It has to do with the fact that this patient's body is not responding to my treatment mechanics the way that other patients respond. And so I decide, that on 8/2013, so August 2013, I'm going to do MOPs, and then I ended up taking a progress photo in March of 2014, and you can see how dramatic those spaces were able to close just after doing one session. There's the progress in July of 2014, and that that was the finish in 12/2014. And you can see I'm not showing you my, ultimate, this is the, greatest case ever. I mean, I'm just picking out a case that we were reactive with, that we're having some difficulties with. And it's not to say that those treatment mechanics couldn't be done without MOPS. It's just to say that when I was in that situation, I wasn't being successful. And by introducing the MOPS, I was able to create success for the patient and get them finished. Is it my best case? It's probably not my best case, but it's interesting to look at these things and learn from them. So here's another additional case that we used micro-osteoperforations in a reactive way. So this patient you can see is a bimax protrusive with a lot of lip incompetency, and you can see a bilateral posterior crossbite, not an easy thing to correct. And of course she's got missing teeth, and so I never take the easy route. But I always take the route that's going to be the best for my patients and is going to give me the best result in the long run. And so here's this patient's cephalometric x-ray, and you can see just how protrusive she is. And so I don't think that I had a choice. I had to extract teeth. So she's already missing teeth. I'm going to be extracting more teeth. Goodness gracious, I don't even know if I'm going to be able to finish this case. So I'm seeing big, huge spaces here. I'm going to be extracting teeth on top. When I start talking to people about this, some people just look at me and go, you're just setting yourself up for failure. And maybe that's true. Maybe not. But let's take a look at this pano. So this was the progress of November 2010. You can see I've taken out the upper bis. I've now started to level and align. I am using Damon mechanics, and I end up using some TADs to help us close these big spaces and deal with the cant. And so here's a progress pano. January 2011, you can see we're beginning to close up the spaces. We're getting some tipping of teeth. Things aren't quite working exactly the way that we want. So here's our progress. And again, I did the MOPS reactive, so I did it after the fact, and I wasn't able to take the series or sequence of pictures along the way that I do for a lot of the patients I do now with acceleration. So here's a progress photo of April 2014. We did one MOP on 5/2013, and when I say MOP, I'm talking about micro-osteoperforations. And typically, in this particular patient, I did those perforations all the way from 7 to 7 because we were closing spaces in the posterior. And so this is what she looked like for 2014 with pretty much most of the spaces closed. The bite on the right side is still not quite resolved. Midlines are off. There's a little cant. And so we ended up using a TAD on the upper right-hand side to resolve the cant. And there's her progress in May of 2014. We still haven't gotten the class 2 corrected on the right side, but we do have all the spaces closed. And we have a great looking profile. And that's what the pano looks like in May of 2014. What I thought was absolutely impossible with passive self-ligating mechanics, TADs, and micro-osteoperforations is now possible without having the patient do implants, which I think probably if we go back and I asked everyone in the group, would you just plan for implants there? I guarantee you everybody would say yes. So I'm not so sure how many people would be excited about closing spaces that look like that. But that's what the patient wanted, and that's what I gave the patient. And I don't think that if I had these mechanics, I would be able to do this. So with twin brackets or with Invisalign, even with MOPS, I don't think that I could have done this. So that's the pano, the progress pano, May 2014. There's July 2014 result in September 2014. You can see she still has a slight little cant there to the occlusal plane, but a great looking smile and a great looking profile and a raving fan. She sends in patients, almost every single month. She loves me. She loves what we did for her. And when you take a look at what was done, I think everybody would agree that it's pretty impressive. And so that's what the profile change looked like. That's what the lips look like afterwards. You can see, there's no resorption of teeth or tooth loss or anything like that or any negative side effects. And that's the final pano. Probably a little bit of some generalized bone loss. Probably not anything that we wouldn't see with just regular orthodontic treatment. But overall, very nice result. So some other additional reactive clinical cases with micro-osteoperforations. So this is a patient, post-surgical space closure with Damons and mops. When she first came to me, I thought, God, this has got to be the easiest case ever. I will just close my eyes, have my assistants do, most of the stuff. Of course, I'll put the brackets on, and this will be a slam dunk. And of course, I'm sure all of us, if you've been in practice long enough, have had a case that looked real easy, and you got started into it, and you're like, how come this isn't happening? So this patient started in November 2012. She just had some spaces, literally just some spaces, distal, mesial and distal of the laterals on top. Maybe a little bit of space distal of the cuspid. So she comes in, presents with, post-surgical. She's got some plates up there. She had a Lefort. One, they brought her upper jaw forward to deal with the prognathic mandible and the class 3 profile, and I think she looks great. I don't think that those screws or plates are going to get in the way of me moving teeth. You can see on this panel, there's just small little spaces in between the teeth. So here's, again, November 2012. Now I go all the way till May of 2013, and I still have spaces. The roots are not getting in the way. The plates are not getting in the way. What's going on? So this picture is a progress of June 3rd, 2014, and I actually did the micro-osteoperforations, the first one in February 25 of 2014. As you can see, the spaces are now actually closed or closing. So that's the progress, 6/24/2014. Space is closed. Still a little hint on that upper right side. You can see we're even using double closing springs here on the upper right side to help get that space closed, plus a power chain. I mean, if I could stand on her teeth, I probably would have. She probably wouldn't have liked me to do that. She's a pretty girl, so mops in this situation is really the only thing I could have done, because I'm using really strong mechanics, using passive self-ligating brackets, and I'm using power chain and closing springs. And so we can actually see that she finally gets all of her spaces closed, mesial and distal of the laterals and the cuspids on the top. And of course, there was a little bit of a bite issue. I had to do a little bit of some adjusting of the lingual surfaces on the upper teeth and a little bit of some IPR on the lower to make that work, but that was the final. And so we were really happy with her result, and so was she. Additional reactive cases. So this patient, also reactive. This is a very interesting case. We have a really nice profile, and we've got severe crowding. And so usually those two things don't go hand in hand. And so I was forced, in my opinion, to take out bicuspids. I don't think that she would have turned out well without me taking out bicuspids, but let's see how it played out. So this is a progress photo of June 2013. Let's go back for a second. That's October 2010. So many years later, with the extraction of the bicuspids, the spaces are still not closing. And you can see that in all of the pictures here. We got midlines lined up and things are looking better, but the spaces are not closed. So we end up doing our first mop, and that's on this picture on June of 2013. And the second one we did in September. And so this is her progress in March of 2014. You can see that now the majority of the spaces are closed. There's still a little bit there. We're even doing double mechanics. We've got closing springs on the labial, and we've got power chains on the lingual. You can see that in all 4 quadrants. So again, it's not so much a limitation on the mechanics, it's the patient's response to the treatment. And so if I want to change the response, then I have to start using some micro-osteoperforations. She ended up getting a little bit of a class 2 there, and so we ended up having to get her onto some elastics. This is what it looked like in 8 of 2014 with all the spaces closed. And then this was October 2014, just prior to her D-band. Spaces closed, bite was all finished. Don't love the cuspid relationship on the left side, but nice class 1 molar cuspid everywhere else. And the profile flattened a little bit, but still looks good. So another proactive clinical case, or excuse me, this is the proactive case. This is a non-surgical treatment plan with micro-osteoperforations and incognito. Patient presented with some incompetent lips and anterior open bite, and she basically chose for a combo of lingual braces and labial braces. So we had clear labial braces on the lower arch, and we had incognito lingual braces on the upper arch. So the initial estimate was 24 to 30 months. She was not interested in surgery. She was not interested in extractions. And so she was just going to close her anterior open bite with elastics, and she would do it no other way. And so we started out with the MOPS. And this is what it looks like with her pano. We ended up having to have her wisdom teeth removed. That's what the stuff looks like with the anterior open bite, fairly significant anterior open bite. And again, this is our final. This is July 2014. It took 17 months to finish. She had 3 MOPS during her treatment. We were able to close her anterior open bite, finish in class 1 molar cuspid. Midlines were slightly off, but the patient was just ecstatic. And when she was done, she ended up doing some cosmetic dentistry to those front teeth, but I never got her back in to take the pictures of what that final cosmetic work was done. But you can see what it was. So again, we started here in February 2013. We estimated 24 to 30 months of treatment, and we started with micro-osteoperforations right at the beginning. We spaced them out about 10 to 12 weeks in between, and she overall finished out on 17 months. I think it was a nice result. That's what she looks like cephalometrically with the bite closed, and this is what it looks like 1 year later without her cosmetic dentistry. And I'm still trying to get her back in to get the pictures with the cosmetic stuff that she told me that she did. I haven't seen it, but I heard from the dentist it looked great. So additional proactive clinical cases with MOPS. So this was another patient. We started her in November 2014. She was estimated at 12 to 18 months. She's got a class 1 cuspid molar, a little bit of a deep bite and some crowding on the lower. So really not a very complicated case, real pretty girl. Finished 2015. We had 9 months in treatment, two micro-osteoperforations, great result, turned out really wonderful. And we did that with incognito and micro-osteoperforations. So an additional proactive clinical case with MOPS. This is fairly recent. This patient started in July last year, or excuse me, 2014. And you can see she's got a real deep bite and some crowding, and nothing too complicated, class 1, molar cuspid. But take a look at what's going on here. We did our first MOP on September 30th, 2015. You can see the deep bite has already been improved, and resolution of crowding has begun. And then this is her MOP number 2, January this year. And you can actually see I started taking the pictures the day of the MOPS. So you can see the little holes, the little perforations, and then you can see how they look like on the second round. And you can see that I'm not doing 3 vertical, and I'm not doing them everywhere. I'm actually reducing the number of perforations, and I'm seeing the same treatment response. And so this patient, we did her second MOP on January 7th, 2016. And about a couple of days later, I got an email from her that she asked me if there were any allergic responses or reactions to micro-osteoperforations. And I told her, no, I haven't seen any. And she said, well, what do you think about these lips? Because I'm really concerned about whether or not there was an allergic reaction to this procedure. And I looked at those pictures and I was like, there is just no way. That is just not. But I figured, okay, I'm going to be a doctor, be caring. And so I sent her an email concerned to ask her if that's what was going on. And of course, she told me no. She just found these, it's like a Halloween costume thing that she put over her mouth. But when I first saw it initially, I was like, oh my God, that can't be. And so I just thought I'd throw that in there as a funny thing. Additional clinical cases with the micro-osteoperforations. These are some impacted cuspids. This is actually not my case, but take a look. Without the micro-osteoperforations, it was estimated as 12 months to bring those lingually positioned, palatally positioned cuspids, and it actually took 6 months with MOPs or MOPs. And you can see the little yellow are where the MOPs were placed, the little yellow dots on the picture. So you can see there were many placed around these impacted cuspids. And so impacted cuspids, because of the thickness of the bone around there and how much remodeling has to occur, we're typically going to be doing more perforations than some of those other recommendations. But I think that this turned out real nice. This was the case I was talking about from Dr. Gwynn, where you can see dramatic reduction in gingival display with using MOPS and very cool mechanics. So originally she estimated that that would take 12 months, and after 1 month of progress, she saw a huge reduction in vertical maxillary excess. Real impressive. And if you read her article, you can see she's got real good records on it. It turned out great. Here's another doctor, Dr. Kathy George. You can see the initial, she's got a pretty good rotation on that lower left first bicuspid. And this is 2 months without any micro-osteoperforations, just a twin bracket and a light NiTi wire. And then 2 months with the perforations, you can see the change that occurred in the position of the tooth. So again, this is time point 1 to time point 2 is the same time frame as time point 2 to time point 3. But one introduced MOPS, the other didn't, and you can see that a 2-month response with no MOPS, the tooth barely moved, and with MOPS, the tooth got into the position that we wanted. So you can just see over and over that scientifically micro-osteoperforations are a sound procedure, and clinically they really, really change the way that I'm doing things, and they'll change the way you're doing things too. So let's talk about marketing micro-osteoperforations to help grow your practice, and then we'll get into some question and answer. So advantages to finishing treatment early. When will my treatment be completed? Now I have an answer. So I get that question every day, probably 50, 60 times a day, although recently I have had a few people that are asking to keep their braces on longer. Don't ask me why, but maybe there's this Gothic thing with having more metal or having things more visible, I don't know. But I have found it strange in the last 5 years I've had patient requests to keep their braces on longer. But it's a very small percentage. Still, the larger percentage is the same question every day that we all deal with. When will my treatment be completed? When will my braces be done? When do I have to, when can I stop wearing these Invisalign aligners? And so now I have an answer. I'll tell them, we could do micro-osteoperforations, and that will get you out of treatment faster. So how will my patients pay for treatment if I finish them early? And that's a big issue with most practitioners, is that they're dealing with some type of a payment plan. And most patients, that's how they're willing to get started. I'll do that $5,000 treatment, and I'll pay you, $250 a month for X number of months, or $150 a month for X number of months, or whatever it is. And so now if we're going to be shortening that length of time that they can pay, then that means that they're going to have to be paying more in shorter periods of time. And a lot of practitioners begin to say, well, I don't know if I can do that. Well, I think that you have to structure your payments in advance. Always has to be a payment agreement, and there has to be verbiage in there that encompasses what we're now going to be introducing, acceleration. So if their treatment gets done sooner, then their overall payment needs to be paid sooner. Their monthly payments could go up if we start to see that we're going to get done sooner. Some people won't change the payment arrangement because they're not sure the patient will respond. I wouldn't recommend that. The patient is going to probably respond, and then you're going to find yourself in a situation where you're trying to collect money that's going to be difficult to collect. So I would usually tell most people in advance that there's a cost to the procedure, it's additional, they will get done faster, which means that they'll have to end up paying more money for that premium service. And so I believe Accelerated Orthodontics is an upgraded service, and it does warrant a higher fee. I think that the profitability, we don't want to cut into our profit. And so what we've found over time is that our cost of living has gone up, but our cost for our treatments have not gone up. And so the ability for us to be profitable has become more and more challenging over the years. And I believe that if you introduce Accelerated Orthodontics into your practice, you will find that you will probably become a little bit more profitable on your cases, and thus become hopefully more excited. So Accelerated Orthodontics can warrant more profit if you're structuring things correctly, but it can also create a lot of hassle in the practice. Didn't structure it in advance with the patients in a written agreement. So what if I finish before they complete their payments? Make sure you have a clause in your contract that the patient pays at the completion date. Typically, we have found that if we wait all the way till that end date, then that can create a problem. So usually when we start to see that we're about 3 or 4 months away from finishing, we start really accelerating their payments. Is this going to make more doctor chair time? And the answer is yes. The doctor will have to sit at the chair to do the perforations. So yes, initially for the micro-osteoperforations, but no overall, because the treatment time is now going to be reduced. And so less overall reduced chair time will ultimately equal more profit. The other thing that we'll do, which I think is kind of cool, is it'll create more capacity in your office. So now you can actually treat more patients with the same number of days and the same amount of effort that you've been doing in the past. So if you're finishing 40 to 50% faster, that means you now have more room in your existing schedule, and you'll be forced to start more cases. I apologize for that. Hopefully that doesn't offend anyone. Your capacity can now grow if you can schedule and collect efficiently. If you maintain the same scheduling and the same collection process, then you'll find yourself a little upside down. Accelerated treatment works best if you can see the patients in shorter intervals for braces and longer intervals for aligners. So we are now going 8 weeks, 10 weeks for our aligner patients, and we're finding very predictable results. And for our braces patients, we're seeing them a little sooner, so we can get that wire change faster or activate the space closure or any type of mechanics that we're doing. Thus, we can overall end the treatment sooner. A practice and doctor differentiator. I believe the advantages to finishing treatment early is it's going to set you apart in your area. So I believe that there's a 2 to 3 year window. I think it will attract new patients looking for faster treatment. And I do think that it can set you apart from the GPs that are doing Invisalign. I do think that the GPs will probably jump on board a little bit faster than the orthodontist will. So I think that the GP's window is smaller. And so what that means for us as orthodontists is that we want to try to see if we can incorporate this procedure and be the leader in our community for accelerated orthodontics versus being responsive to the patient that comes in and says, oh, well, my general dentist is now doing accelerated orthodontics. What do you think about that? So that's probably not the place that you want to be at. Did Invisalign differentiate you? Question mark. Well, it did for me. So I think Propel with Invisalign, it will definitely differentiate you in your area. Now, by saying you do Invisalign, that doesn't mean anything. Everybody does Invisalign. But by saying that you can get their Invisalign done faster and 40% the time, now you become something special in your area. Will it increase confidence in Invisalign and allow for 7 to 10-day intervals? Yeah, I think that's a lot different from the rest. So if everyone in your area is doing 2-week cycles and you're the one advertising, oh, you can change your aligners on a 1-week basis, do you think there are going to be people seeking you out? That's typically what we're finding from the people that are doing this. So how do I charge for this procedure? We charge $250 per treatment, either proactive or reactively. If a patient is interested in buying it for the whole treatment from a proactive perspective, we do charge $800 to $1,200 for full treatment, and that's unlimited number of perforations. And I did tell you that typically I'm usually doing 2. Sometimes on rare occasion I might do 3. I have heard of other practitioners charging between $200 and $300 per treatment. I've also heard of practitioners charging $300 to $800 for 2 treatments. Ultimately, you can charge whatever it is that you want, whatever value you can create for the patient. I always think if you can charge more, better. Patients usually only need 2 to 3 treatments since the cellular response lasts up to 12 weeks. Tips are valued at anywhere between $100 to $150 each, based on the amount that you buy. Obviously, if you buy more, you're going to get a lower price. Ultimately, the way I started is I just started buying their initial kit. And after I used those up, where I got to, maybe I had 1 more or 2 more left, then I ordered more. And what I found is that I didn't have to, at the beginning, keep a very large inventory because I didn't have a lot of patients that were interested. In fact, I was a little bit skeptical. Once I totally saw that these things were helping the patients, these procedures, I thought, wow, maybe I should have a little bit more on hand. And then, of course, once I started, ramping up the number of people that I was treating with it, then I started ordering more and more. And of course, the initial group was those drivers with the lights, and once we used those up, then we went to the reusable handles with the disposable tips. I went to the next slide a little bit too fast. Build your web presence with Dr. Locator. So just like Invisalign has Dr. Locator and Ormco has, Damon has Dr. Locator, Propel does as well. So if anyone is searching common terms like, accelerated orthodontics or faster treatment or faster braces, then these names will pop up. Now these are the keywords that we can start optimizing for if you have optimization in your in your website. If you're doing SEO, then what you can do is use these keywords like Propel or straight teeth fast or faster braces or fast braces or fast Invisalign or fast orthodontics, and these are all things that you can optimize for, and you can start using it in your website and your web pages. These are some example brochures that were created by Propel. You know, you can do the same thing, and you can add the Propel logos on there. You can add your doctor's name on them. So there's some cool stuff out there that you can use. There's some sample like letters, for example, that we've used, or we send out to our new patients or our existing patients about something that's exciting for us. The existing patients, we've also done things like a letter like this where we actually offer a gift certificate for $250 off. So it's basically one free Propel treatment. And we've done this to get patients back in for our uncommitted patients that didn't start the same day, or if we were trying to do a special for a month or a quarter, and we decided to throw it out there. And for me to give a $250 treatment and the patient is going to get done sooner in treatment, I think it's a worthwhile investment because really it doesn't cost me the $250. But even if I calculated all my time and maybe it cost me $350 and I get done with the case 6 months earlier, 6 months earlier is worth a lot more than whatever it is that it cost me. And so this is just a way to encourage parents and siblings to to promote your services to their friends and family members, and they're getting a discount, and their friends could get a discount. This is another brochure. We display it in different areas in the office, but it basically ties in straight teeth to periodontal disease to overall general health issues. And I'm sure everybody's seen these pictures and have some of these things in their reception areas, but the overall body is related to the mouth, and if we don't have a clean mouth, we don't have good dental health, we're going to end up having overall health issues. And so we talk about that and stress that. And then we use this brochure to show before and after micro-osteoperforation scenarios, and then we also show about the driver and the device and that it's FDA approved, and you can go to their website or you could go to my website and check it out. And so these are samples of this is my website on the upper left side. These are some other samples of a couple other people's websites that they're also promoting and talking about Propel, and they have a page on their website about either Accelerated Orthodontics or Propel Orthodontics or faster treatment, or however they want to title it. And then build your web presence. You can do blogs to start talking about Propel. You can do mass newsletters if people are still doing the snail mail stuff, or even if they're doing it on email. But getting the information out there that this is something that you're interested in, and this is a sample of Dr. Hickory or Dr. Robinson's blog where they're writing about Propel and how they're introducing Accelerated Orthodontics into their practice. So in conclusion, I think you can grow your practice with Accelerated Orthodontics using micro-osteoperforations. If you have any questions or you need anything from me, that's my email, and those are my two websites. I have one website for Los Angeles and one website for Beverly Hills. And so at this point, my part of the presentation is completed, and what I was hoping for is for some questions. And so I see a list of questions here. So what I'll do is I'll just start with the first one, and I'll repeat the question, and I will explain what it is that's going on. Okay. So the first question is, please address frequency of micro-perforations. When Propel came out, you said 3 perforations interdentally every 6 to 8 weeks. Now Invisalign protocol is every 15 weeks. 1 perforation every other tooth. Have you changed your protocol as well? I'm not at 15 weeks. I'm at 10 to 12 weeks in between. I was doing 3 perforations, mesial and distal, interdentally. I now sometimes do 2. I sometimes do 1, just depending on how much effect I want to create. So on patients that have a little bit softer bone and a little thinner tissues, I'm going to be doing a little less. And patients that have very thick, very dense bone, very thick tissue, I'm probably going to be doing a little bit more. But I'm not in any way following an Invisalign protocol for perforations on a 15-week cycle. It's usually going to be 10 to 12. But that's a great question. I got a comment that the audio is poor. Hopefully that got improved along the way. Are there studies of reforming bone density after ortho treatment in postmenopausal women? Is the question. And the answer to that, are there studies of reforming bone density after ortho treatment in postmenopausal women? I've not read any of those studies, but I'm sure that there's probably some information out there. Obviously, the same hormones that affect all of us affect women in a very big way postmenopausal, and so the effect probably would be, some change in bone density, which would potentially have an effect on their overall orthodontic treatment. But fortunately, in my practice, the patients that I've treated that are postmenopausal, I haven't seen a dramatic, decrease in treatment time or an increase in their treatment length just due to the bone density, or I haven't seen a decrease in treatment time due to a decrease in bone density. So I clinically or anecdotally would say no, but I'm sure that there's probably some more definitive studies that could describe that better than I could. Next question, is there an indication for palatal mops other than canines? I think if you're doing intrusion for anterior open bites, I think that mops could be used in the posterior in the palate for intrusion, posterior intrusion with TADs. All cases show in the buccal gingiva only, mops in the buccal area greater than the 6 to 10 millimeters active zone, so wouldn't palatal perforations be indicated? Yes, palatal perforations are indicated. Could you perforate both buccally and lingually? You could. The studies showed that when we did the perforations on the facial, there was more of an effect than when we did the perforations on the lingual. And part of the reason why is because the cortical plate on the facial is much closer to the actual teeth than the cortical bone on the lingual. So, so yes, it is indicated. Is it indicated on all teeth in every area for every situation? No. And that's part of the reason why we mainly focused on the buccal perforations. So that was a great question too. Buccal perforations being greater than 10 millimeters from the palatal roots in the posterior area. I don't know if that was a question. Let me see if I can get it again. Buccal perforations being greater than 10 millimeters from the palatal roots in the posterior areas. So I don't understand. I don't get the question. Maybe someone could repeat it or rewrite it. The next question is, do you know if this is approved in Canada? And the answer is yes, it is approved in Canada. In fact, there is, I think, 1 rep or maybe even 2 reps now in Canada that can help you get that. Is the compounded topical strong enough for palatal anesthesia? Again, that's going to be on a patient-specific situation. So I have found that there are some patients that I use the compounded topical and they don't have any problems, whether it's either palatal or facial or buccal. But I have found that there are some patients that are very sensitive that even if I use the compounding topical, I have to still use a local anesthetic, so a little shot. Usually I'll use a small syringe with a lidocaine, like 1 to 100,000 epi, and I'm usually not going for nerve blocks. I'm just going for local infiltration. Is the NSAID throughout the entire treatment or just 24 hours after the micro-osteoperforations? The recommendation for no NSAIDs is going to be throughout the treatment. We don't want them using any NSAIDs at all. If we know that there's going to be a decrease in tooth movement based on a decrease in cytokine response, another way of saying that is that if they're going to be taking those NSAIDs, they're going to see a decrease in the rate of their tooth movement. I had someone tell me something funny. They said, well, it's not really funny, but they said, if you charge your patients for over-treatment, then you should be recommending NSAIDs. But if your goal is to try to get your patients done on time or sooner, then you should be recommending that they do no NSAIDs at all throughout the whole treatment is going to be the best thing for them. Now, there are some situations where patients potentially may need those NSAIDs because they have other problems, arthritic problems or issues like that. And those types of patients we're going to find we're going to have a little bit more of a difficult time being able to control things, because if they go back on their NSAIDs, then it's going to have a counteractive effect of what we've done with the micro-osteoperforations. So if there are any other questions, please go ahead and type those questions in there. I'm going to take you back to the last slide. And I just want to thank everybody for spending their evening with me. Again, quite an honor. I know that there was, at one point, I think almost 70 people signed up here. And so I was really excited to present this information. I hope that it helped everybody. This is my email, and again, my 2 websites. If you have any questions, please feel free to email me at any time about this procedure or anything I can do to help you get it integrated. Otherwise, it's been a pleasure.